In too many countries, people live and die without ever having seen a health worker. This chronic shortage of health staff, estimated globally to be more than 4 million, is one of the most serious constraints to progress in health and development. And it's a problem made worse by health worker migration. Poor countries that spend their limited resources training medical staff often see them leave for better pay and conditions abroad, leaving already weak health systems in crisis.
Large number of medical officers, the doctors, they leave the country within 2 years of the training, within 2 years of graduation, so the investment is lost.
The exodus of trained health workers to hospitals in the West is nothing new. In the 1980s, it was said there were more Malawian doctors in Manchester, in the UK, than there were in Malawi. Many, like Brian Kubwalo, came to train. He's been working here for the past 9 years while training as a specialist in gynecology and obstetrics.
Who's your baby? People who've been in my position before have wanted to go back to Malawi and work, but have not been able to do that for very many different reasons. Some people, it's issues about their children. Sometimes it has been the actual remuneration, how much they would earn, and whether that would translate into a sensible living for them. This is my final year of training, so I'm at a point where I should decide, should I go back and work in Malawi, or should I stay and work here?
It's a difficult decision. And of those Malawian doctors like Brian, who've gone abroad for specialist training, half never go back. Pakistan, just like Malawi, found that in an era of globalization, the medical professionals they trained to international standards quickly became tradable commodities. Dr. Sheikh is head of the Global Health Workforce Alliance, a global body set up to tackle the worldwide shortage of health workers, including the issue of health worker migration or brain drain.
It is critical that the countries who are facing shortages of workers, they invest more, they produce more, and they create an environment where the health workers stay within that environment.
The number of trained doctors in Pakistan has doubled in the last 15 years. But Pakistan also recognised the need to fill the gap between the few medical staff they had and the communities that needed them most, those in rural areas. In 1994, Pakistan introduced a new kind of rural health worker. Lady health workers, like Nazim Akhtar, raise awareness and provide primary health care to their own communities.
It's a good job, and since I've started, I've learnt so much about myself and about health.
Being permanently based within her community means Nazim can spot if someone needs to be referred early and arrange for them to be taken quickly to the nearest health centre. Those who may have ignored their symptoms or left it too late to seek help are now reaching doctors and nurses sooner.
While we are working on producing more doctors, while we're working on the issue of migration and the brain drain, we can create a new cadre of worker within the community. In the long term, we may not need that kind of number of doctors as well. If we provide some basic services through these community health workers, and then the next level, the doctor may come in terms of emergency and other services.
Lady health workers have helped slash infant mortality rates by 35% in the areas where they work. Cost effective, quick to train, and not likely to leave the country, community health workers like these are increasingly being seen as a crucial element in improving health systems starved of doctors and nurses. Malawi has one of the lowest ratios of health workers to population in Africa. There are only about 250 doctors serving the entire country of over 12 million people. So nurses often step up to fill roles that in the West would be done by doctors, like assisting in surgery. But also, just like doctors, registered nurses have a qualification in demand overseas, and that makes them prone to brain drain too. So many doctors and nurses were leaving that in 2004, the Malawi government and donor agencies launched the Emergency Human Resources Programme to train and most importantly retain more health workers. So desperate was the crisis that an idea previously thought unsustainable was introduced: salary top-ups. But while the top-ups helped, tax and subsequent inflation means nurses are still struggling.
Sometimes I say, I think this is just cheap labor, because what I'm doing there is not what I'm being paid for.
Okay.
Yeah, I do a great job, a big job, but when it comes to what you get at the end of the month, it's just very hard to get by.
The number of nurses leaving Malawi has slowed, but many are still choosing to go. Yanko's training was part funded by a charity, so for now she's tied into a training bond. But she's clear about what she wants to do when that expires.
I would say yes, I would come. I would live.
While nurses here are still finding it hard to make ends meet, the situation for doctors is better. As well as receiving salary top-ups, they're getting involved with teaching and research, making a Malawian doctor's career both more rewarding and more profitable. And the emergency HR program has helped ensure that 3 times more Malawian doctors are now being trained in country, while those wishing to specialise are sent to South Africa instead of the UK. As a result, today's student doctors seem much more likely to stay. Here at least, change is slowly happening, but brain drain remains a huge problem across the developing world. To solve it, it must be seen for what it really is, a simple case of supply and demand, where health workers, just like any other resource, are part of the global economy.
It's a global problem, and that's why the dialogue has to involve both the source and the recipient countries, both the rich and the poorer countries. There is what we call a global code of practice, which is right now under discussion in the WHO. The recruitment or the migration should be between the source and the recipient countries, so that both sides, it becomes a win-win situation.
The migration of health workers between countries will to some extent probably always happen. The challenge is making it fair.